You may want to know, okay, patients want to know, what are the risks? They are rare, but they do include seizures. However, when I say rare, the incidence of seizures is 1 per 60,000 sessions. A patient only has to do 36. Mania, why would it cause mania? It is a treatment for depression. Any treatment for depression, you always run the risk of mania. So you got to rule out bipolar disorder. The caveat is they have proven in studies, in actual experiments and control studies, that it can still help, especially in a depressive episode. However, would you need as much treatments for that? Probably not. But just keep in mind that it can happen anytime at all you treat somebody for depression if you don't really rule out bipolar disorder. Hearing loss, how does that happen? Hearing loss can only happen really if during the treatment, the machine is pretty loud. You got to make sure you got to give those earplugs to the patients. But I know lots of patients don't even use the earplugs. It just depends on the power and the strength of how much they need. But, you can potentially have hearing loss. Migraines. Migraines is a potential side effect, meaning that if they have a history of migraines, they could have it with TMS. And I've had to stop at least one patient who developed migraines that couldn't tolerate the treatment, no matter how low I set the power, or no matter how many times I adjusted it, they just couldn't tolerate the treatment. So those are the rare side effects, but those are the biggest dangers of TMS. But if you're looking at that, I think even patients, you would educate them. They're willing to take that risk if they feel that bad. The potential side effects, and these are the things that most people complain of: scalp discomfort and pain at the coil where it is, headaches, tingling and spasms or twitching. Why would it do that? Because you may have hit the facial nerve, and that's why you have to just adjust it based on the rotation in order to get it away from that facial nerve. There are some people, yes, some can get lightheaded. However, these side effects are moderate, even mild, and they improve after several sessions. So if the patient is having that beginning, just tell them, keep an eye on it. Let's see how you do the next week or two. If it goes away, it goes away. If it doesn't, then we have to come back and rethink the location, or we may have to rethink the entire treatment. Only when a patient can truly no longer tolerate the treatment. There are a couple of things we can do to reduce side effects. And these are the things that you need to keep in mind, and that you can help alleviate some of the distress in the patient that may be having those side effects. Sometimes we just have to adjust the level of stimulation to reduce the symptoms. So the certain power that we have, we just have to bring it down, the starting power. I tell my patients, just take like a 400 to 800 milligram of Motrin right before treatment. Usually they get used to the treatment. They won't have to do that after a week or two of starting the treatment. So now it comes to the fun part. Before, there was a lot of hoops and hurdles to get TMS paid for by insurance. However, this was last year, Medicare, which is the guideline and standard that all insurances, private insurances, have to follow. So I use this all the time to argue with insurances, they refuse to pay it. So this is coming from Medicare, which is CMS guidelines. You have to have depression, but look at this, it's single. It doesn't have to be recurrent. If a patient is having a single episode, how long does it take for a single episode? 2 weeks, or any depressive episodes, right? 2 weeks. And then you're starting the patient on meds, doesn't work, can't tolerate it, and they're still depressed, they can't get out of it, start another medicine. But if that's not working, then it's perfectly fine to refer a patient for TMS. So this is the following criteria, so only 3, really simple to remember. As we talked about, confirmed diagnosis of severe MDD. And how do you do that? Of course, it's clinical, but we use our scoring scales, such as PHQ-9. Most of the time, depending on the insurance, they can always try to fight you on that. Sometimes they say 18 is not good enough. That's pretty high, but sometimes you got to make sure that they have a PHQ-9 at 20, because they will fight you on this, because it is costly, even though at the long run, it will actually be cheaper, because you get that patient back to work and functioning in life. And they may not need to take medications for life. I've seen that happen with TMS. Failure of one or more psychiatric meds or intolerance to the medication. That's bundled into one, the second criteria. And pretty simple, the psychiatrist has to be the one to evaluate the patient, do the face-to-face, and order the TMS. So at any time at all, Medicare guidelines, maybe a little bit looser, maybe for private insurances, not sure, but a doctor, the psychiatrist, MD or DO, has to be the one to determine if they do meet criteria for TMS. That's why I'm moving on now to not just doing regular med management. My role really a lot in both offices is to determine who meets criteria for TMS, because providers are struggling with finding the right medicine. How do you define failure of a trial of pharmacologic agent? This has to be one or more at adequate dose or duration. So insurances will fight you on that, saying, well, they didn't try it long enough and you did not give a good dose. You may give a P dose. However, second part of the criteria, intolerance, whether it's a low dose, if they can't tolerate it, you could already say they failed that medicine. What is intolerance? They have side effects that don't resolve with continued administration of the medication. You may want to just tell a patient you got to take it every day, but if you really cannot tolerate it, even at a few days, it's so bad, I cannot handle it. That is intolerance. And that is a side effect that you can use as criteria to meet for TMS. This is where people can get stuck, and there are absolute contraindications according to Medicare guidelines. The first one is a medically implanted magnetic device less than or equal to 30 cms from the TMS magnetic core. So think it's up here. And what are those metals? Cochlear implant, implanted cardiac defibrillator, pacemaker. You just have to make sure you measure, but then I usually just say, I'm not going to clear you for this. You need to talk to your cardiologist. And I've had cardiologists say no. So you got to do your due diligence. You got to work with your team. You got to work with other doctors to really make sure that the patient is going to be safe to do the treatment. Vagus nerve stimulators, as we know, this was a treatment for depression, but I think they're using it a lot now in neurological conditions. And any kind of metal, clips and aneurysms, staples or stents, just depends on where it is in the body and is it more than 30 cm from where you're going to do the treatment. So what are the relative contraindications? Seizure disorder or history of it. When patients have this condition, if they have not had a seizure in years and they're stable under treatment, I still get a neurologist to say yay or nay. There are exceptions to the rule. If you've had maybe one seizure and you're not getting treatment for it, or you're getting a seizure from ECT or benign febrile seizures as an infant, that's not really a true contraindication. Psychosis. Why would we want to think about psychosis? Well, as you know, with TMS, it increases dopamine, but you also have to weigh out the risk and benefits. If they're that depressed, they will need some help, and especially if they're not responding to medications. And you will get insurances to deny, but then you can just say, hey, this is only a relative contraindication. It is not absolute. And I believe my patient can benefit from because they've tried everything else. Neurological conditions, as we talked about, epilepsy, which is seizure disorder, cerebrovascular disease, strokes, things like that, dementia. So you will get insurances to deny because they have dementia, but people have dementia, they can still suffer from major depressive disorder, which is the only criteria that needs to be passed in order for your patient to get the approval from the insurances, including Medicare. And increased intracranial pressure, definitely, like I would have to think about that. I would get the neurologist involved, as well as repetitive or severe head trauma. Remember, this is relative contraindication. And what does TMS do? It actually causes brain healing by increasing brain-derived neurotrophic factor. So I was very, very happy to see in that documentary movie, Quiet Explosion, they use TMS to treat these NFL players for their brain injury. Because why? They are suffering from depression and nothing works. If the brain is sick and you cannot get it better with medications, you have to get the brain well by increasing the brain-derived neurotrophic factor. And of course, tumors, again, you're going to have to coordinate care with the neurologist to make sure that they are actually safe to do TMS.